Welcome to today's webinar titled, What Women Need to Know About Heart Health. We are thrilled to have with us today Navy Lieutenant Commander Dr. Lauren Weber. Dr. Lauren Weber is a cardiologist at Walter Reed National Military Medical Center in Bethesda, Maryland, received her Doctor of Medicine degree from the Uniformed Services University of the Health Services in 2007. Prior to obtaining her medical degree, Dr. Weber attended the University of Florida, where she obtained a bachelor's degree with a double major in nutrition sciences and zoology. Without further delay, I will turn things over to Dr. Weber.
Hi, thank you, Stan, for that introduction, and welcome to the audience. I am absolutely honored to be able to be here with you today and talk about women and heart disease. So let's get started. I do need to just start with a disclaimer that the appearance of hyperlinks does not constitute endorsement by the Department of Defense of this website or the information, products, or services contained therein. For other than authorized activities such as military exchanges and morale, welfare, and recreation sites, the DoD does not exercise any editorial control over the information you may find at these locations. Such links are provided consistent with the stated purpose of the Department of Defense sponsored webinar. All right, so this is the roadmap of what we're going to talk about today. I'm going to define heart disease, and we're going to talk a little bit about some facts that I think are important for people to know. We'll talk about the risk factors for heart disease, and then the signs and symptoms of heart disease, as well as how those signs and symptoms differ between men and women. I'm also going to talk about if you have a concern, what are the steps that you should take to do next, and if you make it to the cardiologist's office, what you can expect at that visit. I'm briefly going to go over some heart testing that is commonplace for us to order in terms of evaluation of heart disease. And then we'll talk a little bit about disease prevention and maintenance, as well as go over some of the opportunities that you have through your TRICARE beneficiary status. All right, so what is heart disease? So I think heart disease is a little bit of a nebulous term, and the reason why is because there's lots of conditions that affect the heart, including being born with an abnormal heart as in congenital heart disease, having an abnormal heart rhythm like atrial fibrillation, or diseases that affect the heart valves like aortic stenosis. I unfortunately don't have time to talk about those important diseases. So in general, when I refer to heart disease, I'm talking about coronary artery disease or a condition known as coronary atherosclerosis. The coronary atherosclerosis is a mouthful, but essentially it's a disease of the blood vessels that involves a mixture of plaque or cholesterol, platelets, which are the cells in your blood that clot your blood and stop bleeding, and other inflammatory debris that can cause narrowing of the artery, leading to reduced blood flow and blood flow to the heart muscle, and in some cases, a heart attack. So facts about heart disease. So heart disease, which includes in terms of tracking, not only coronary artery disease, but also hypertension or high blood pressure and stroke, remains the #1 killer of both men and women in the United States. That accounts for every 1 in 3 deaths and claims a life about every 38 seconds. So as I mentioned on the previous slide, the heart disease is also the #1 killer of women in the United States. 1 in 4 women will die of heart disease, while only 1 in 30 women will die of breast cancer. I say that not to underplay the importance of breast cancer in women's health, but really to highlight what a good job the American College of Oncology and breast cancer awareness groups have done highlighting this important disease process in women. Indeed, in my clinical practice, what I have noticed is that women generally are more aware of their risks for breast cancer than they are for heart disease. And because of that, unfortunately, I think a lot of women may suffer a delay in diagnosis because they don't know to think about their symptoms potentially coming from their heart. So what are the risk factors for heart disease? About 80% of women between the ages of 40 and 60 have at least one risk factor for heart disease. And I tend to list risk factors really into two big bins, which are the modifiable risk factors and the non-modifiable risk factors. So non-modifiable risk factors are things I can't change about you. So age, I cannot change your age. It does increase your increasing age increases your cardiovascular risk. Gender, so men are at greater risk for heart disease than women. Family history is a very important and I think underappreciated risk factor for heart disease. If you have a family member who had early onset heart disease, which we defined as a heart attack or stroke earlier than the age of 55 in men, or earlier than the age of 65 in women, that means that you too are at an increased risk for developing heart disease. And then race. So African Americans and Hispanics unfortunately suffer higher rates of high blood pressure and diabetes than their Caucasian counterparts, and that is a risk factor for heart disease. So let's talk a little bit about modifiable risk factors. So those are the things that we can change or control and hopefully decrease your risk of having a heart attack or stroke. I put smoking right at the top of the list because this is really the #1 thing that I can do for patients in terms of decreasing their likelihood of having a cardiovascular event. So if you are a smoker out there and you're thinking about quitting or you've tried to quit before, go ahead and try again. It takes a lot to try to quit. The average smoker attempts quitting 7 times before they're successful. And we in the medical community, both in primary care and cardiology, are here to help you as much as we can. So the other risk factors that we can treat are things like high cholesterol, high blood pressure, diabetes or prediabetes, obesity, and leading a sedentary lifestyle is also a modifiable risk factor. So let's dive in a little bit more to some of those things that we can control. So I want to start with obesity, and I wanted to start by kind of just defining what obesity is. Obesity is defined as having a body mass index of over 30. Your body mass index takes into account your weight and your height. It's not perfect, so if you happen to be a very short bodybuilder, you will have an elevated body mass index. But for those of us who are not challenging or channeling our inner Arnold Schwarzenegger, this is a pretty good start to kind of figure out where we sit in terms of a healthy weight. So a normal body mass index is between 18.5 and 24.9. If you have a BMI of 25, then you are classified as overweight, and a BMI over 30, then you fall into the obesity category. If you're following along with me on a computer, I would encourage you to also Google the NHLBI body mass index, or you can do this later and get a good sense of where you stand in terms of healthy weight. All right, so high blood pressure. So blood pressure is the pressure that the circulating blood has on the walls of your arteries. And recently there's been studies that maybe we aren't being aggressive enough in terms of treating high blood pressure. So they actually lowered the cutoff for the definition of high blood pressure or hypertension, with now normal blood pressure being defined as less than 120 over 80. Just so that you've heard these terms before, the top number is called the systolic blood pressure and the bottom number is called the diastolic blood pressure. I have often been asked which number is more important, and to be honest, they're both important. The younger you are, the more likely you are to have an elevated bottom number or diastolic blood pressure. So it's important really to consider both numbers when we're talking about diagnosis and treatment. You may be wondering kind of what's the big deal about blood pressure? So I like to use the analogy of water through a hose. So if you were to put your heart at the end of a garden hose and the hose was just trickling water through, probably your heart would be fine. But if you were to attach your heart to the end of, let's say, a pressure washer, where all of that high-powered water and flow is pounding into the heart, you can imagine that the heart might be damaged. And your heart is not the only organ that sees all that elevated pressure. Your brain, your kidneys, really all of your organs see that, and that can cause damage over time. So how is it diagnosed? If you have 2 doctor's visits where your blood pressure is greater than 130 over 80, or if you're monitoring your blood pressure at home and the average is greater than 135 over 85, we would consider that consistent with the diagnosis of hypertension or high blood pressure. I have lots of patients who come to me and say, you know, my blood pressure is really only elevated when I go to the doctor. And that is called white coat hypertension. It's considered to be kind of an interplay for just the anxiety and uncomfortableness of going to the doctor. A lot of times you're going for a reason, which is anxiety provoking in and of itself, which can cause an elevation in blood pressure. If you're concerned that you have white coat hypertension, I encourage you to talk with your provider about ambulatory blood pressure monitoring. That's where you wear a blood pressure essentially all day while you're at home, so we can get a sense of what your blood pressure looks like out of the box. I do want to use a caveat here to say that if your blood pressure in the doctor's office is greater than 160 over 100, you should still be treated for high blood pressure, really regardless of what your numbers are at home. All right, so cholesterol. Cholesterol is a fat-like substance found in animal products that is used in the body in a variety of ways, including healthy ways like lining our cells. Not all cholesterol is the same, however, and some cholesterol sticks to vessel walls inside the arteries around your heart and hardens over time, causing plaque. LDL, or bad cholesterol, is the type of cholesterol that clogs arteries and increases your risk of a heart attack or stroke. Your body and my body naturally make LDL, and how much we make is really is a number of factors influenced by our genetics, but also what we eat. There are higher amounts of LDL found in saturated fats and trans fat substances. HDL, or good cholesterol, has really the opposite effect. So we know that having a low good cholesterol or HDL level actually increases your risk of having a heart attack or stroke. And there's been a lot of data that suggests that having a higher HDL level may actually be protective against heart attack and stroke. From a treatment perspective, we are very good at lowering LDL or bad cholesterol, but we have not yet developed great medications or therapies to artificially raise your good cholesterol. So really the only way to do that is through regular aerobic exercise and a healthy diet. What number should you aim for? So total cholesterol of less than 200 is considered normal. If it's very high, greater than 240, that actually doubles your risk of having a heart attack or a stroke. For good cholesterol, we like to see that number 60 or higher, and again, that may be protective of heart disease. And we consider a number less than 50 to be a risk factor, meaning it may increase your risk of having a heart attack or a stroke. For LDL, you're kind of in that borderline zone if your LDL is between 130 and 159. I consider it high if it's greater than 160, and I consider it very high, sort of dangerously high, if it's greater than 190. If you have a bad cholesterol and LDL level of 190, I would strongly recommend that that needs to be lowered not only with diet and exercise, but also with medication. Okay, diabetes. So diabetes and prediabetes are disorders in blood sugar handling that over time lead to dysfunction in really multiple body systems. So by having an elevated sugar level and sugar circulating in the blood, it can cause a lot of inflammation and even deposits of protein within the different organs themselves, which decreases their ability to do their job. We want a goal to have a goal fasting blood sugar of less than 100. And fasting is when you haven't eaten or drank anything for about 12 hours, and then you get your blood sugar measured. The American Heart Association recommends no more than 6 teaspoons or 100 calories a day of sugar for women. I think it's difficult to kind of measure how much you're taking in teaspoons because on labels, everything's listed in grams. So that you have kind of the conversion, 6 teaspoons is really no more than 24 grams of sugar a day. All right, so let's talk about the signs and symptoms of heart disease. So we've all seen that scene in the TV or the movie where there's a gentleman who clutches his chest in agonizing pain and goes to the hospital and is diagnosed with a heart attack. And while I do see that presentation in my clinical practice, I would say more often than not, the diagnosis in the presentation is a little bit more subtle. A lot of patients tell me that they don't have chest pain, they have chest discomfort. I've actually gone away from using the term pain in my clinical practice when I talk to patients because I am really sort of struck by how many patients notice that they feel pressure in the chest or fullness or squeezing. And so those all, I think, kind of encompass that chest discomfort that could be a warning sign of a heart attack. Other signs that you might see or feel are shortness of breath, pain in one or both arms, pain that radiates to the jaw or neck, nausea, and dizziness. The symptoms of heart disease are very similar to those of a heart attack, but they're often a little bit milder. You want to pay attention to the symptoms that are new or worsening over time. And then another symptom that I find very useful and also very important is if you've noticed a decrease in your exercise capacity or activity tolerance. So I use the example of if you could always walk up 2 flights of stairs with no problem, and now you're having trouble completing just 1 flight of stairs, either for profound fatigue or difficulty breathing or chest discomfort, that is certainly a symptom that you want to pay attention to and bring to the attention of your doctor. So chest discomfort is still the most common symptom of heart disease and heart attacks in women. However, women are much more likely to experience these less specific symptoms associated with heart disease, like shortness of breath and nausea. The American Heart Association put forth a scientific statement a couple of years ago and said that we need to pay attention to these less specific symptoms. For instance, shoulder pain or arm pain was twice as predictive of having the diagnosis of a heart attack in women than it was in their male counterparts. The other differences that we need to realize about women is that women often present at an older age than their male colleagues with heart disease. And because they're older, they have more health problems at the time of diagnosis, including high blood pressure, kidney disease, and diabetes. Really, no matter what their age, however, women are more likely to die, have heart failure, and suffer a stroke within 5 years of their first heart attack. They are also less likely to receive appropriate medical therapy and timely invasive therapies. I say all of that really to highlight the fact that I think the delay in diagnosis and this less likely to be treated appropriately may have to do with those more subtle symptoms, in which case, I think it's important for women, again, to become aware of what the symptoms may be and to bring those symptoms to the attention of their doctor. So if it's subtle, how do you know? So remember, chest discomfort is still the most common symptom of heart disease in women. If you're experiencing one of the other more subtle symptoms, what I would say is pay attention to kind of what's going on. When do you notice it? Is it exertional? How often does it happen? Is it happening more frequently or getting worse with time? Is there reliable triggers and anything you can do that you know will bring on the symptoms? And then when you are having the discomfort or shortness of breath, are there other symptoms associated with it? So if you have a concern, what should you do? So first, I want to say, if you have a sudden onset of severe symptoms, chest discomfort, shortness of breath, or any of the other symptoms I mentioned, you should call 911 and go right to the hospital. It is estimated that people wait anywhere from 2 to 5 hours before deciding to go to the hospital for a heart attack, and that is just far too long. Much like in stroke, where time is brain, time is heart muscle in terms of a heart attack. So it is really important to get to the hospital and get appropriate treatment. If you're concerned about your symptoms, but they're not severe, especially though if they've been getting worse over time, you should start by making an appointment with your primary care provider. Getting a good history, physical exam, review of your vital signs and EKG can help your doctor determine whether or not you need to see a cardiologist. And if you make it to the cardiologist visit, what can you expect? So really, this is the time to tell your story. Try coming armed with as many details as possible. I find it helpful too that if you have a spouse or friend who has kind of watched you have some of these symptoms, it's often helpful to bring them along, because in ourselves, we often underestimate kind of how we've been feeling or even how we've been impacted by our symptoms. We are going to review your medical history and an EKG, and then any recent lab data that was collected, including your kidney function, cholesterol, and blood sugar. And then we will talk about testing if it is indicated. So we have a lot of tests in cardiology, and I won't go through all of them, but I just kind of wanted to give you an overview of some of the things that we can do. So really the workhorse of heart testing in cardiology is echocardiography. That is a heart ultrasound. It is the same technology used to view babies when mothers are pregnant, and it is a great look at the structure and function of the heart. It is not a direct look of the arteries or blockages within arteries. But if you have a significantly blocked artery, we can often pick that up on ultrasound through looking at the heart function. And then if we're concerned that you may have a blocked artery, we often will order a stress test of some kind. And we have lots of different kinds of stress tests. More or less, they all involve generally supervised exercise with patients on a treadmill while we watch them exercise and we watch their EKG under exercise, with potentially some images of what the heart is doing. I have a variety of patients who, for whatever reason, cannot walk on a treadmill, either because of musculoskeletal injuries or severe arthritis. And for those patients, we have good options too, where we can give them medications to simulate exercise and still evaluate their heart under stress-like conditions. Anatomic testing is where we try to take a look at the heart arteries themselves to look for plaque inside of the artery. We can do that invasively through a left heart catheterization. And now there's spreading technology, technology that we have here at Walter Reed, where we non-invasively look at arteries with a CAT scan to look for plaque and evidence of blockages. I'll say one other test here that I didn't put up on the slide, but that is calcium scoring, and that's because it was in the news recently, which is a good screen for plaque, very similar to the CT scan that I just mentioned. It doesn't tell the level of blockage, but it's a good screening tool to see if there's any evidence of plaque around the heart. All right, for prevention. So we talked a lot about heart disease. Really, our goal is to hopefully prevent all of this from happening so you never have to see us in the office. I think one of the things that you can do for yourself is keep track of your numbers. So we talk about so much when we go to the doctor's office. It's often hard when you get home to remember, well, what was my bad cholesterol? What did they say my A1C was? So feel free to jot those things down. I would say leverage technology. Almost all of us are carrying around smartphones at this point. So this is a great way to track your progress, especially if you and your doctor are trying to target one of these risk factors to make your numbers better. And then manage your risk factors. So we already talked about quitting smoking. If you're prescribed medications for one of these conditions like high blood pressure or high cholesterol, it's really important that you take those medications as prescribed. And then we also want you to eat right and stay active. So healthy lifestyle is one of these things that is very easy to say to people, but it's very difficult, I think, in real life. We're all very busy. Our general tenets are to advise you to maintain a healthy weight, so that's a body mass index of less than 25. And for diet, there's so many diets out there. I have lots of patients ask me, well, which one is best? And I sort of will tell them that I think it kind of depends on your goal. I think for weight loss, really all of these diets, the Mediterranean, vegan, vegetarian, paleo, work for weight loss, as long as you stick to them. For heart health, I tend to recommend the Mediterranean diet. The Mediterranean diet, from my perspective, really sort of focuses on more of adopting a healthy eating habit so much as a diet. It's a whole food, plant-based diet where you eat meat in moderation and mostly focus on plants and vegetables to make up the bulk of your caloric intake. And there's been good evidence in several trials to support that that is probably the best diet you can be on in terms of preventing having a heart attack or stroke. Exercise. All right, so the toting line and the recommendation from my professional society is that you have a goal of 30 minutes of at least moderate level exercise 5 times a week. So moderate level exercise is things like jogging, the elliptical, the stair stepper, swimming, biking, etc. That's pretty hard to do. So really being active is a great way to still get heart health. We do want to go for that moderate level of exercise, but even walking helps condition your heart and keep you healthy. So, I think a little bit the choices we make for exercise have to fit into our lifestyle. Really, my tenet is just move more. Try not to take the elevator, take the stairs. Park as far as you possibly can from your office building or where you work so that you have to walk in from the parking lot. And if you're on the phone, just walk and talk around so that you're getting in those extra steps. All right, so I feel like I threw a lot of information at you. We covered a lot, and if you're feeling a little overwhelmed, that's okay. If you want more help and you're to review some simple steps, you can search online for My Life Check through the American Heart Association and try to calculate your heart score by entering in just a couple of values. And then they are going to give you a list of a simple 7-step process to increase your heart health. If you're a TRICARE beneficiary and listening, TRICARE does offer several cardiovascular screening tools, which is cholesterol and blood pressure checking. The TRICARE covers age-specific and periodic lipid, which is just cholesterol panels, as recommended by the NHLBI. For children, that is a blood pressure check annually between the ages of 3 and 6, and then every 2 years thereafter. And for adults, that's at least every 2 years. If you have any further questions, you can visit www.tricare.mil/covered services for more information about what's available in your area. These are my references. I would like to thank you for listening today and for joining us. And at this time, I'd be happy to answer any questions.
Thank you, Dr. Weber. We do have some questions that have come in, so I will get started with those. The first question reads, I have been on a medically supervised ketogenic diet for 13 months, gone from BMI of 53 down to 36, and still dropping. All my lipids, sugars, and BP numbers have dropped in spite of this. Could this diet that is higher in fat hurt my heart long term? I eat 30 grams total carbs a day, 80 grams or less of protein. The rest is fat from a variety of sources.
Yeah, so that is a really great question, and I would like to start by saying congratulations for lowering your BMI so drastically. That's really an accomplishment. There's been a lot of controversy in the media lately about what the role of fat and cholesterol is for heart disease. My general tenet is to kind of stick with what has been studied in the past until we get some compelling data otherwise. Which is generally to try to keep a diet lower in cholesterol and fat. If your cholesterol numbers overall are controlled on your diet or with medications where the total is less than 200 and that bad cholesterol number is less than 130, I think that you're okay to continue on the diet that you're on.
Okay, thank you. Next question reads, what role does sugar intake affect high blood pressure?
Good question. So sugar intake, through kind of a couple of different complicated mechanisms, can lead to diabetes, and it also can lead to holding on to water. So the more water that you have kind of in your system, which is a little bit more complicated than just the water you ingest, but the water that's being held onto in your blood vessels increases the pressure that the blood vessels have to circulate around and then onto your arteries. And then diabetes themselves also can cause kidney dysfunction, which over time can also lead to high blood pressure. So all three are sort of intimately connected in terms of sugar intake, the development of prediabetes or diabetes, and then ultimately high blood pressure, generally due to kidney injury.
Okay, thank you. Next question, where do I find out more about cardio-electrical system and malfunctions? Everyone talks about cholesterol, but not electrical or inflammation problems.
Yeah, so it's a good question. My father is an electrical engineer, and he often will have this conversation with me about what does the electrical portion play in heart disease. And right now, what I can tell you in terms of heart disease related to what we talked about, which is that plaque forming in the arteries, we don't see a strong link between electrical disorders or what we would consider abnormal rhythms or arrhythmias as a risk factor of developing heart disease. So I consider them kind of two separate portions of cardiology in terms of electrical disorders or abnormal rhythms, treating those differently than I do treating heart disease because of cholesterol and plaque. Inflammation is also a concept that is gaining more and more popularity amongst cardiologists and I think generalists in terms of being a risk factor for plaque development within arteries and causing artery narrowing. So if you have an inflammatory condition like rheumatoid arthritis, those are conditions that you should work in concert with not only your rheumatologist, but also your general internist and possibly a cardiologist about being really aggressive to treat those risk factors that we mentioned, because it's an under-recognized risk factor, I think, that inflammation in terms of causing heart disease.
Okay, thank you. Next question reads, how often do you recommend a fairly healthy woman in their 60s getting preventive blood test screening?
blood test screening. So I assume that you're talking about cholesterol and blood sugar testing. You know, from my standpoint, I like to check every 1 to 2 years, I would say. You know, and I guess it depends a little bit on kind of where you're starting from, but even patients that I have on therapy for cholesterol, there's no official recommendation for us to check at any specific periodic interval, but I like to check about once a year just to make sure that we're still on track. And I think that certainly if something has been flagged where you are working on it with your doctor, it's reasonable to check once a year just to make sure that everybody's kind of heading in the right direction in terms of your numbers.
Okay, and the second part of that question, at what frequency rate does TRICARE authorize routine blood screening?
Good question. I'm going to defer that one to Francine, our TRICARE specialist, for her guidance.
This is Francine, and I'm just going to go ahead and go into the manuals to confirm that is. So when you're saying, again, are we talking about the cholesterol screening and all that sort of stuff? Give me a couple minutes. I will come back with you with the answer.
Okay,
Thanks,
I'll go on to the next question. If you don't want to take the cholesterol lowering medication because of possible side effects, how many IU of vitamin E is recommended?
Okay, so good question. I should mention here that vitamin E has not in any strong way been shown to lower bad cholesterol, which is really what we are trying to do with medications. The other thing to know about vitamin E is that it is a fat-soluble vitamin, meaning that you store it in your body once you take it. So it is possible to take too much and become toxic on it. The standard recommendation is, I believe, about 400 IU for vitamin E, and I would recommend not taking any more than that max dose of recommendation. In general, when you're looking at vitamin supplements, what I tell folks is that, you know, read those labels very carefully. A lot of times you'll see that supplements carry what I consider to be sort of super doses of a lot of the vitamins and minerals. So if something contains more than 100% of any vitamin or mineral, you probably don't. You have to remember that not in addition to your vitamins, you're also getting those nutrients through what you eat. And we want to try to avoid the toxic effects of some of those high levels of vitamins.
Okay, thank you. Next question reads, if you don't have high blood pressure or high cholesterol, can you still have heart disease? How would you know prior to actually having a heart attack?
Yeah, so it is possible to have heart disease in the absence of high blood pressure or high cholesterol. And we consider those patients with heart disease who don't have any of those risk factors generally to be driven by their genetics. So, you know, what you picked up from your family. It's sometimes very difficult to tell. And I've had some young patients who don't have any other medical problems who come in and their first presentation to a cardiologist is because they're having a heart attack. If you're not having any symptoms, you know, really there's no way for us to tell ahead of time. One of the reasons that I like to tell people to exercise outside of the fact that it is good for your heart is that exercise often sort of serve as a built-in warning system. So if you have a blocked artery and you're leading a kind of a relatively sedentary lifestyle, you may not know until you have a heart attack. But if you're exercising, it's possible that you're going to see changes in your exercises first. So maybe not chest discomfort, but again, kind of that fatigue level. So if you were always able to run 2 miles, and now you can't even get halfway there and you don't know why, it's just very difficult. That can be one of those very subtle but early signs of heart disease that would prompt either your generalist or a cardiologist to take a look and make sure that there's no evidence of a blocked artery.
Okay, next question reads, My blood pressure averages 140-ish, over 100-ish, sometimes 95 plus. Also, I'm overweight and take 2 different blood pressure medications. I need to exercise more and have started to eat a lot better. My cholesterol is under 200 with good cholesterol being high. Do I need to have a physical from my primary care doctor, or do I need to see a cardiologist?
So good question. I think from the numbers that you reported, I would still say that you need work and management for the blood pressure, which should be lower, even despite the fact that you're on 2 blood pressure medications. So that can be done either through your primary care provider, or sometimes, after 2 medications, primary care providers don't feel as comfortable, and so they refer on to a cardiologist for management of blood pressure. So either one would be fine. I think the starting place really is to go back to your primary provider and have a reassessment of your blood pressure and see if they feel comfortable adjusting your therapy.
Okay, thank you. The next question reads, I have Hashimoto's, I'm not sure if I'm pronouncing that correctly, thyroiditis, and I'm MTHFR positive. What does this do to my risk factors? I'm 59. My father had his first heart attack at age 60. This is lingering in the back of my mind.
Yeah. So I think good points all around. So thyroiditis is an autoimmune disorder for the audience that inflammatory conditions that I mentioned. Generally a little less so than things like rheumatoid arthritis or lupus. Autoimmune diseases do serve, I think, as a risk factor for heart disease. And since you have somebody in your family, albeit a little bit older with your father, but since you do have somebody in your family who has heart disease, I think it would be important for you to go to your primary care provider and make sure that all of your numbers are okay. So make sure that your blood pressure and if those things are not normal, then lifestyle modification for a trial of 6 months to see if we can make those numbers better.
Dr. Weber, your audio is not coming through as clear as you were in the beginning. I'm not sure if you may want to just repeat some of your answer.
Hey, Stan, are you able to hear me?
It still sounds like you're breaking up a little bit.
Okay. All right. I was just mentioning that Hashimoto's thyroiditis is an autoimmune disorder. And I think it does fall into the category of inflammatory conditions, although a little less so than rheumatoid arthritis or something like lupus. But nonetheless, because it's autoimmune disease and you have family history, that he was a little bit older than what we would consider for early onset heart disease, it would be important to go to your primary care provider to make sure essentially that all of your risk factors are controlled. So a blood pressure check, a cholesterol check, and then if those numbers are abnormal, either targeting them with a trial of diet and exercise, which I usually only recommend for about 6 months, or initiating.
Okay, thank you. Next question reads, I've read several research articles about the use of statins for high cholesterol. A concern is the reporting findings that statins can accelerate the onset of diabetes 2 symptoms. If a person were to stop taking the statins, would there be a possibility of reversal, your body returning to previous state of the symptoms of diabetes 2?
Yeah, so there has been certainly a lot of information in the press, and my field has taken a lot of interest into the statins potentially kind of accelerating the progression to diabetes. It's a sticky subject, you know, so I think that folks that are at risk for high cholesterol tend also to be at risk for diabetes to cause it, or essentially that it unmasks this process. Regardless, one of the biggest risk factors that to kind of help decrease people's risk of heart disease. I have not seen yet where either in my clinical practice or, you know, by consultation with my colleagues, where if we stop the statin, I've not seen somebody revert their diabetes back to normal.
Okay, thank you. The next question reads, I'm 65 with some risk factors of heart disease. I've read about taking a baby aspirin daily. Is that something that is recommended as a precaution?
Yeah, for the most part, there's a little bit, you'll find a little bit of variation which doctor you talk to, but I think at the age of 65 with some risk factors of heart disease, I feel very comfortable recommending daily baby aspirin for heart health.
Okay, thank you. Francine is ready to go to answer the response from earlier.
Right. Okay. I'm just going to mirror what the commander has said before, is really you're very reliant on what your primary care is identifying as symptoms and your risk factors based on your age and your gender and all those kinds of things. So for TRICARE, a lot of this testing is very much in the screening basis. And the manuals indicate that we do cholesterol screening for children once between the age of 9 and 11, and again between the ages of 17 and 21. And for men, usually a cholesterol screening, again, age 35 and older, and men and women age 20 and older who are at increased risk for heart disease. So it goes back to what she said previously. How are you? What are you feeling? What are your symptoms? What's going on with you? Blood pressure screening. Again, most of these things are done in your primary care manager's office or your primary care doctor's office. Blood pressure screening, we indicate that we do it, well, we would cover it at least every 2 years after the age of 6. But because this session is about women's health care, there's also under TRICARE, and I got to scroll up here really fast, that we do cover a woman's, what do I want to call, preventive care type visit. It's called a well woman exam. And the purpose of the well woman exam, it's covered annually for females under age 65. And if the primary care doctor determines that a patient needs annual well woman visits to obtain necessary preventive services, which would be your cholesterol screening, your blood pressure screening, that sort of thing, they can be provided to our beneficiary population, the female beneficiary population. For those on the line, for just in general, TRICARE does cover a health promotion and disease prevention visit for ages 6 years and older, and one health prevention and health promotion and disease prevention visit is covered annually. But you have to make very sure that when that provider is submitting that claim, your primary care doctor or whomever you're seeing is submitting the claim is designating that type of visit. Sometimes they'll put in, you know, just exam, physical exam, which might not necessarily be the same code that is used for a health promotion and disease prevention visit. So until that claim actually goes through and gets processed, there's no guarantee of payment, but be aware that that is available to you. That's all I have.
Thank you, Francine, for that TRICARE information. The next question reads, a friend died of broken heart syndrome. Can you explain that and what you can do to prevent it after losing a spouse or loved one?
Yeah, so broken heart syndrome is a very specific type of cardiomyopathy, which is a disease that affects the heart muscle. It occurs of a heart attack, and so women are particularly at risk for broken heart syndrome. It usually occurs after a particularly emotional event like the death of a loved one, or sometimes even a significant illness. What ends up happening is that women will have signs and symptoms of a heart attack, and sometimes have heart failure where they develop fluid on the lungs or fluid in the legs and have deep breathing. We medically treat the patients, meaning we try to help them sort of through that, and then the heart muscle, by and large, tends to recover on its own, although not in every case. So I'm very sorry to hear about your friend. In terms of prevention, we have no good way to prevent broken heart syndrome. What I would say is it's some of it is to kind of be aware of how you're feeling, especially during times of trial or traumatic events. So if you are feeling particularly low or depressed or upset about an event like that, to talk to your provider early about mental assistance with depression and bereavement to try to avoid this deleterious effect on the heart.
Okay, thank you. The next question reads, how effective is taking omega-3 fatty acids, fish oil, in lowering cholesterol and prevention of heart issues?
So there's a big article that came out within the cardiology journals actually showing no benefit to taking omega-3 fatty acids from a heart disease standpoint. That being said, I have lots of patients who like to take omega-3 fatty acids. I think that there's not a lot of downside to taking one. So if you wanted to use it in concert with kind of a healthy lifestyle, a healthy diet, that is okay. If you're taking it primarily to avoid medication therapy for cholesterol, that I would advise against, just because they've been shown to really just not be as effective as the medications that we have.
Okay, thank you. At this time, I don't see any other questions in the queue. So I would like to thank you, Dr. Weber, for sharing your invaluable experience and expertise. I would also like to thank our attendees for participating and submitting their questions in today's webinar. And if you find yourself having questions after the webinar is over, please email moswebinars@militaryonesource.com, and I'll send the questions over to our presenter and get an answer back to you as soon as we can. Dr. Weber, did you want to close with anything before I actually conclude the webinar?
No, I just want to say it was a pleasure. I really appreciate all the audience participation, and hopefully this was helpful to all of you.
Okay, thank you. With that being said, this concludes today's webinar on what women need to know about heart health. Thank you all for attending, and have a great day.